And the overview of the progress can be summarized in a slide, because the treatment of CLL has moved in the last 25 years from the classical wait-and-see approach to chlorambucil to the real landmark of the introduction of fludarabine provided by Michael Keating at the Anderson, next to the introduction again by Michael Keating of the chemoimmunotherapy with FCR, followed by the studies of the German CLL study group. And more recently, we have a really impressive numbers of new drugs and even the capacity to manipulate the T cells with the CAR, which has been pioneered by Carl June. In the meanwhile, the idea of treatment is based upon risk, low versus high risk. And the number of prognostic predictive factors have emerged over the years. And the prognostic factors are telling us which are the probability of disease progression. They give us the capacity to decide the frequency of follow-up controls, and among them some have emerged from the basic biology, like the IgHV genes, ZAP70 and CD38. While predictive factors are telling us which is the probability of response to therapy, and cytogenetics remains the main aspect of these predictive factors, but new genetic markers are emerging, and they possibly will allow us to select which is the best therapy. Over these years, there is honestly an impressively increasing number of complete remissions in CLL, starting from chlorambucil, ending up with FCR. And even more interesting, and this is a slide that I hold to the courtesy of Michael Keating, FCR time to progression by the mutational status of IG in the patient is showing that after 12 years, in the cases who have been treated by FCR, there is absolutely no progression. So the question is whether by defining properly the patient, we might be able to personalize treatment, and as an example, whether immunoglobulin mutated CLL patients may be cured by FCR. Now, we still have to consider that the diagnosis of CLL is made usually around 72 years of age, that about 70% of the patients are over 65, and that the first treatment is frequently started around 75 years of age. That implies the obvious concept of fit, unfit, and frail. And even more important, the problem is that if we consider how many patients over 70 years, who are the bulk of the patients, are undergoing clinical trials, we have to take note of the fact that even in areas like the MD Anderson or the German CLL study group, the number of these patients is extremely low. So we are extrapolating data that not necessarily are already applied to the general population of patients. Now, there are reasons for developing new agents and new treatment strategies. One is that most patients cannot be treated with chemoimmunotherapy, that the complete remission rate is in the range of 40–60%, that most patients relapse. I had written all, but then the FCR in the mutated group made me change my mind, that the toxicity of chemoimmunotherapy, FCR, is not negligible, that the immune function is not restored. There may be one possible exception in patients treated with lenalidomide, who show a normalization of circulating immunoglobulin levels, that there are patients who are refractory to fludarabine, and they are not a negligible proportion of patients, that there are no good salvage therapy with the exception of allogeneic bone marrow transplantation, but the transplant-related mortality again is not negligible, and that major advances have been made in understanding the biology of the disease. And the biology of the disease was telling us, which is the roadmap of CLL, can be summarized by thinking that there is the interplay of genomic abnormalities, antigen experience, and microenvironment promoting effect. So the take-home message of the biology is that CLL is a very dynamic disease with considerable genetic complexity, and I'm sure that Carl will elaborate upon that, and that key players in the microenvironment are essential for the survival of CLL cells. So where does it all start? It is quite conceivable that all scenes have long shadows. And actually there is a genetic susceptibility, it has become clear, with a familial tendency, with an increased number of monoclonal B-cell lymphocytosis among CLL relatives. So the question, and I'm sure that people like Neil Kay will elaborate upon MBL, but the question is, given enough time, will all MBL evolve into overt CLL? And if so, which driving forces open the doors to the selects? And the main aspects that I wish to take into account then are, well, no unique molecular abnormality, but critical genetic alterations, and Carl will elaborate upon that, the key role of antigen stimulation and BCR signaling, the key role of microenvironment crosstalk, and the relevant implication which are the issue of MBL and genetic susceptibility, and I will briefly touch upon the issue of subclones. Now, as for the B-cell receptor signaling, it has become clear by a number of publications over these years that there are critical signaling steps vulnerable to inhibition, and so we have a whole range of new drugs which have entered the clinical arena. However, the BCR signaling in CLL is heterogeneous. As a general statement, we might say that patients with bad prognosis their cells tend to undergo proliferation upon antigen stimulation, while, again, always in very broad terms, patients with good prognosis, their cells tend to be energized by the antigen stimulation. And energy is a reversible lethargic state. Now, fact is that even if we have anergic cells, some of them circulating enter in the tissues, and once in the tissue, they start proliferating. So the question is that really, in a sense, anergic cells are a major clonal reservoir, and that we have to take into account this major clonal reservoir. Now, all critical events of CLL occur in tissues, especially in niches, and the most important niche is represented by pseudofollicles. What about pseudofollicles? Well, they are the proliferating areas where all the cells are BCL2 positive, and thanks to Carlo and his group, it appeared that this BCL2 is a crucial gene, and it's interesting because as they are BCL2 positive, they are all bound to survive. And another aspect, which again links genetics with microenvironment, is that the proliferating cells become or have to become P27-KIP1 negative. P27 is a cyclin-dependent kinase inhibitor, which becomes negative because when there is the toll-like receptor stimulation, this upregulates a cluster of microRNA, which in turn downregulated the P27. Now, besides the niches, and within the niches and outside the niches, there are a whole range of different cell populations that represent the microenvironment. And the interesting aspect is that when we draw cartoons, we tend to make a drawing with one malignant cell and one accessory or microenvironment cell. While on the contrary, we have to consider that in CLL tissues, the number of malignant cells way outnumber overnumbers the number of microenvironmental elements. So there must be an important signal amplifications by the cells of the microenvironment. And within these cells, T cells are especially involved in the proliferation, while the accessory cells are especially involved in the survival of malignant cells. Another aspect which has to be considered of the microenvironment is that we have a whole range of molecules and of potential signals. Now, the question is, which is the individual weight of the different molecules and different signals? And we usually approach, or over the years, the problem has been approached by animal models, but this approach is remembering the famous Indian fable of the six blind man describing an elephant. Everyone is thinking that what is taking care of is one thing, and possibly the most important one, while we have always to consider that we have to put individual molecules within the broad context, within the broad picture. Now, clearly, the microenvironment is a two-edged sword, and it may be pro-tumoral or anti-tumoral, and it has become clear that as time is passing by, the pro-tumoral activity is ongoing, while the anti-tumoral activities takes place only in the early phase and is easily overcome. Still, as I mentioned at the beginning, the CAR approach, pioneered by Carl June, may allow the immune system anti-tumoral to strike back. Now, the issue of subclones is interesting because next-generation sequencing is allowing to quantify mutations in restricted population of CLL cells, and the number of publications have clearly shown that there is an evolutionary biography of CLL cells. And this brings in one of the most relevant questions, because the unmet medical needs are, do we want to control the disease or do we want to eliminate the disease? The issue of reaching the MRD negative status. And also we have to eliminate the disease-related complication. But even more important, how do we integrate the novel drugs into the current trials and treatment paradigms? Which leads us to the most relevant questions that are, who should be treated? And when should treatment be started? I'm saying that because there are a number of ideas right now to modify our treatment paradigms utilizing drugs that are not chemotherapy. So the question is, which will be the role of chemo in the future? Possibly the fact that it has been shown that in patients with mutated gene, FCR may be curative treatment, means that perhaps we cannot talk in a black and white sense, but there are a whole range of grays. Now, catastrophes usually depend upon a combination of errors as time goes by, and the studies performed by Nick Chirazi with the heavy water are clearly showing that CLL clones are definitely more dynamic than we presumed. That implies that they have an increased proliferation, and the increased proliferation entails increased genetic risks. That means that time matters. And again, the question is, when do we have to start treatment? Even also because the proportion of patients who are diagnosed in early stage and usually therefore are not treated is increasing steadily over the years. So we are facing a changing population of patients that we are watching. And what I think, to conclude, is that we have seen over these years new cellular protagonists, novel molecular targets, which have led to the development of novel treatments that likely will be developed to harness the tumor cell microenvironment crosstalk, and the clinical applicability of this novel therapy will move the field of treatment of CLL from cacophony to symphony. And I thank you very much for your attention.